Good morning, everyone. Today I'm going to present on how to approach a patient uh, with non-functional pituitary adenomas. I'm going to cover the definition, the epidemiology, pathophysiology, clinical features, investigation, and management. I'm going to begin the presentation with a case. This is a 59-year-old male present to emergency with worsening vision in the left eye, referred by ophthalmologist. His vision problem started since 2018 and was lost to follow-up and then turned up in August 2022. He complained of blurring of left peripheral vision, which worsened over 2 years with no associated headaches. He has low libido and decreased sexual drive for 10 years with normal development of axillary and pubic hair. He didn't complain of tiredness nor any GI symptom. On examination, he didn't have any cushingoid nor acromegalic features. He was overweight with a BP of 130/70 and pulse of 88 per minute. His left eye showed decreased visual acuity of 6/24 with left temporal defect. He had a normal color vision and normal fundus. His rest of the systems were normal. His investigation showed normal WBC count, hemoglobin platelets, and TSH of 0.9 and a T4 of 9.5, which was low. He had normal UNEs with a random cortisol level of 326 and low FSH, low LH, and a low testosterone level with mildly elevated prolactin levels. He was later sent for a visual field testing, which showed a bitemporal defect. And later the imaging showed, which is MRI pituitary, showed a large mass sitting in the sella turcica, which is extending above. The sella and extending inferiorly and also laterally to the cavernous sinus. So what is the diagnosis? So in this patient we had a deficiency in TSH, T4, a low random cortisol level, and mildly elevated prolactin level with low LH, FSH, and low testosterone levels. So this patient clearly had anterior pituitary hormone deficiency with visual field defect, and cause is a large mass present in the sella turcica, which is a non-functional pituitary macroadenoma. A brief overview on pituitary adenomas. Pituitary adenomas may present incidentally on routine examination or due to abnormal hormone profile, or may present as visual field defect. It comprises 10% of all intracranial tumors, out of which 30 to 40% are NFPAs. What is NFPA? It is a benign neoplasm that originates from adenohypophyseal cells and are not associated with clinical evidence of hypersecretion. It is rarely malignant. A size of more than 10 mm is considered as macroadenoma, a size of less than 10 mm microadenoma. They are literally common tumors presented between 6 to 8 decades of life. It is estimated with an estimated prevalence of 7 to 41 cases per 100,000 population. The slow-growing tumor can be missed at initial presentation. An acute presentation, which is a life-threatening condition known as pituitary apoplexy. What is the pathophysiology of pituitary adenoma? In 95% of cases, it occurs sporadically due to defect in various genes or due to epigenetic changes. And in 5% of cases can present hereditary in the form of endocrine syndrome-associated tumors such as MEN1, PRKR1A genes, which are the genes responsible for MEN type 1 and kinase complex. It can be present as familial isolated pituitary adenomas due to defect in AIP gene, which is a tumor suppressor gene. Both of them contribute to monoclonal expansion of pituitary cell, leading to pituitary microadenoma, and later presented macroadenoma. or it can even present due to it can even present as a clinically silent pituitary adenoma because of tumor senescence, where there is arrested growth in the pituitary cell tumors. What are the different types of NFPAs? We have the most common being gonadotroph adenomas, which is 73% of cases, seen in 73% of cases. And we have the second most common, which is the corticotroph adenomas, and then the PIT1 lineage tumors, and the last one is the null cell adenoma. How the non-functional pituitary adenomas are classified based on the pituitary hormone expression and due to transcription factor profile. They are basically divided into silent pituitary adenomas and null cell adenoma, which doesn't express any pituitary hormone transcription profile, factor profile. The most common non-functional pituitary adenoma is the gonadotroph adenomas, which expresses FSH beta and LH beta subunits. It also expresses transcription factors SF1 and GATA1. How do non-functional pituitary, how do patient can present with headaches due to stretching of dura mater in 20% of cases, 20% with visual disturbance due to field defects, and the most common being bitemporal heminopia seen in 70% of cases. Can present as ophthalmoplegia due to close proximity to cavernous sinus, which harbors the 3rd, 4th, and 6th cranial nerves. It can present with loss of color vision. Can cause mass effect due to pituitary stalk compression, and also can compresses the anterior pituitary tract, leading to hypopituitarism. It can present as pituitary apoplexy in the form of severe headaches and cranial deficits due to hemorrhage into the tumor. Diabetes insipidus is a rare feature and can occur most commonly after surgery. Now, the order of hormone deficiency is the most common hormone affected. The beginning is the growth hormone, followed by gonadotropin-releasing hormone, TSH and ACTH. Patient present with growth hormone deficiency, which may present as tiredness and fatigueness, non-specific symptoms, and presenting with a reduced quality of life. I can present with hypogonadism due to direct pressure of tumor to the gonadotroph cells, or due to stark disconnection effect, which inhibits the release of dopamine from the hypothalamus, leading to increased prolactin secretion. Can present with central hypothyroidism and secondary adrenal insufficiency or central adrenal insufficiency. Now, how do we investigate a patient with non-functional pituitary adenoma? At first, we need to assess the pituitary function, whether the tumor is functioning or a non-functioning tumor. This is very important because there are tumors, functional tumors such as prolactinomas, that can be easily treated with medications. And once we check the anterior pituitary hormone profile and there is a deficiency, then the patient will go for a visual field examination either by the Humphrey testing or the Goldman's perimetry. Once the anterior, after that the tumor should be located with imaging. The most common imaging used is MRI. And if there is a syndromic presentation, then functional tumors should be suspected, such as Menn type 1, Canis complex, and McCune-Albright syndrome. These are the images of a patient with pituitary adenoma. You can see an enlarged pituitary adenoma, which is a macroadenoma, which is extending above the sella and which extends inferiorly into the sella tertia, and which extends laterally into the cavernous sinus. And this is another picture which shows that this is a T1 weighted image of the pituitary showing a hemorrhage within the tumor. and this is seen nicely in this T2 weighted image showing a whitish coloration, which represents as the blood within the tumor. Now, how to evaluate the patients of pituitary adenomas? Basically evaluating the tumors into functioning and non-functioning. Non-functioning tumors should go for, depending on the size, micro or macroadenoma. All macroadenomas should go for a visual field testing and anti-pituitary hormone profile check. If there is a deficiency in the anti-pituitary hormones followed by visual field defect, the patient will go for surgery. If the testing is normal, then you have to repeat MRI probably every 6 months to know the progress of the tumor. And depending on that, if there is a new growth or if there is a visual field defect, the patient will go for surgery. Out of this functional pituitary adenoma, platinum is the only tumor or the tumor which has good response rate to medications. Now, how you manage a patient with non-functional pituitary adenoma? Surgery is the most definitive choice for non-functional pituitary adenoma. The most common surgery done is the transsphenoidal adenectomy, which helps in reduction of the mass effect, which corrects the visual field defects and which corrects the hypopituitarism as well. The remission rate depends upon the type, nature, and size of tumor. The remission rate for a microadenoma is around 80%, and macroadenoma is about 50 to 60%. Pre-op evaluation should be done for all patients who are subjected to surgery with a T4 and adrenal status. This is the image of a transsphenoidal splenectomy done through the nasal approach. You can see the endoscope goes via nasally, enters the cella thoracica, enters the sphenoid sinus, and then cella thoracica, and then removing the tumor. This is the pre-op and post-op images of a patient who has undergone a surgery. You can see the post-op shows a complete removal of tumor. Now, during and after surgery, patient should have adequate perioperative cough with hydrocortisone. Cortisol level should be checked between day 0 to day 7. If cortisol level improves, it shows a gain of pituitary function. But if cortisol level is less than 2 nanogram per liter, then hydrocortisone should be started at once. TFT levels should be checked and replaced if low T4 levels. Review should be done after 6 weeks with a repeat of anterior pituitary hormone profile. MRI scan should be done within 3 to 6 months, and if normal, then it can be done on a daily basis. Now, surgeons use a shape clearing system to predict the surgical outcome of the disease. In a retrospective single center study, which included 191 NFPAs who were followed up for 59 months, showed a total resection. A total resection was achieved in 53% of cases, with decreasing likelihood of accomplishment in higher shapes. A tumor recurrence was seen in 6% of cases. In another retrospective analysis of 155 patients with NFPAs with a mean follow-up of 6 years, relapse was seen in 34% of cases, with 20% of relapse seen after 10 years. Radiotherapy, when combined with surgery, showed excellent response in NFPA patients. It's mainly done as a combination therapy, or in patients who had relapse, or if it is a large tumor with the probability of recurrence, or if tumor extends laterally into the cavernous sinus with tumors with high proliferative index, known as the Ki67 index. The only risk for this procedure is hypopituitarism. What are the different medications used in NFPAs? Actually, medications are of less importance here. It's mainly used in functional tumors and invasive pituitary carcinomas. Some tumors express the dopamine receptors and somatostatin receptors, which is the basis of mechanism of action. For example, silent lactotropes or silent somatotropes dopamine agonist, and somatostatin analogs can be used. Temozolomide, which is an alkylating agent, is used in aggressive pituitary adenoma tumors, but less effective in non-FPAs. One of the latest treatment for non-FPA is peptide receptor radionuclide therapy, which is used in which is currently under study and used in few patients with aggressive pituitary tumors. In summary, pituitary tumors are common cellular masses, and NFPA comprises almost 50% of them. It often presents visual field defects or present routinely routine examination as an anti-pituitary hormone deficiency. If present with sudden headaches, then you have to always suspect pituitary apoplexy, which is a life-threatening condition and needs surgical intervention. Most of them recover from hormone dysfunction after surgery, and replacements should be given for those if deficiencies are noted postoperatively. Thank you.